Hello, I'm Kate Wakelin from Neuroendocrine Cancer Australia, and I'm beaming into you from Melbourne. So I just wanted to tell you that I am sitting in Wurundjeri land here in Melbourne on the banks of the Yarra River, which is called Birrarung. And the Wurundjeri people are part of the Kulin Nation. And I just wanted to pay my respects to their elders past and present and emerging. I would love to welcome our guest speaker, who's Dr. Daniel Cehic, and you might recognise the surname. So I'm going to let Daniel explain to us how that might be a familiar name to all of us. Daniel is a cardiologist with a particular interest in cancer and cardiology, which is, I think, a pretty amazing set of features and skills and interests to have for a person who's visiting a neuroendocrine tumour support group, because our patients have lots of needs in this area, and so I'm really looking forward to hearing what Daniel's got to say to us.
Thank you, Kate, and good evening, everyone, and thanks for joining, and to Jessica, who's trying to dial in again. I thank you for the invitation to have a chat to you all. So my name is Daniel Cehic. We're going to start. The talk is about probably 20 to 30 minutes. Then, as Kate said, there'll be questions. Happy to answer any questions that you like at the end. In terms of the name that Kate mentioned, so Gabrielle is my wife, or rather I should say I'm her husband. She's actually the more important of the two of us, quite clearly. So I hear a lot about NET all the time and have done for a few decades. So I'm certainly not an oncologist or an endocrinologist, but I sort of have a degree of understanding of NET from an oncological perspective as a result of that relationship. So I am, as I said, I'm a cardiologist. I've got a subspecialty interest in what's called cardio-oncology, which I'll explain a bit more in due course. And I'm also trained as an electrophysiologist. So that's a pacemaker. I'm an electrician of the heart, basically, in my original training before I became interested in oncology. I happen to be based in Adelaide, and I am, however, the Chief Medical Officer for Cardiology for an organisation called Genesis Care. Genesis Care is the largest cardiology and oncology network in Australia, and it's an international organisation. The oncology is mainly radiation oncology, but there certainly is some medical oncology and also theranostics, but mainly in Western Australia and New South Wales. So in terms of cardio-oncology, what is it? It's a relatively new discipline, if you like, in medicine. And Susan Dent is a medical oncologist originally from Canada, based now in the US. And she describes it as a discipline focused on the cardiovascular health of cancer patients and cancer survivors. And it's a very broad topic. And covers a range of cancers and treatments, because the cancer itself can affect the heart, and a lot of the cancer therapies, not so much in NET, but in other malignancies, can certainly affect the heart. And really, it's a discipline that has come to the fore probably in the last 5 to 10 years. And prior to that, cardiologists tended to shy away, and actually a number of cardiologists can be a bit scared of cancer themselves. It's a completely foreign world with different therapies and different drugs, and not such a great understanding from a cardiologist perspective. But that's certainly changing. And there's a number of cardiologists now around the country, and a number in South Australia, who are interested in cardio-oncology. So I'm going to give you a very brief Cook's tour of the heart. I'm sure you probably, I know, as Kate said, everyone's different. I'm sure you've all got different levels of understanding. You're at different levels of your treatment and journey through your net. So I'm going to start off at a baseline, and I'm sorry if it's repetitive or boring for some who know it already, but I'm just going for the broad audience. So look, what is the heart? The heart's about the size of a fist, sits in the chest. This is a nice artistic representation of the heart. It's basically just a muscular pump, and it pumps blood around the body. If you slice the heart, and can you see my cursor on the screen? Yep. So there are basically two sides to the heart. This side here is called the right heart, and this side over here is called the left heart. It doesn't actually, it's not on the left and right side of the body, it's just how it's termed, so don't think of it as like left and right hand. And the two sides of the heart are separated and don't really join in terms of blood flow, because the heart operates more in a figure of 8. So blood comes from the body into the right heart, and the blood that comes from the body has all or a lot of the oxygen and nutrients taken out of it. And the right heart pumps the blood into the lungs, where the oxygen is put back in, and that's what makes the blood redder than the one where oxygen is not there. Then it pumps blood into the left side of the heart, which then pumps it out to the body. So it's a figure of 8 continuous pump. It's actually an amazing part of the body. If you were to get your fists and pump it once a second for a long time, your fist is going to get quite sore. Your heart's been doing that since before you were born and never stops. And so it's an amazing piece of muscle that really nobody understands how it does what it does. If we go back to this diagram, you'll see that importantly, there are valves in the heart. There is one here and one here on the left-hand side, and there's one here and one here, sorry, on the right-hand side, and one here and one here on the left-hand side. And these usually, if they are functioning properly, will act as one-way valves to allow the blood to flow into this chamber pushes it into here. And when this squeezes, and you can see this is quite a big muscular chamber, when this squeezes and pushes blood out, it'll also try to push it back this way, and this valve will actually stop it from going back into here. And so, and again, and as it goes through this valve, it stops the blood from flowing back. And so these are one-way valves that are important. And if we slice the heart in a different plane, these are the 4 valves as they are anatomically. And the valves that we're interested in today in particular is this valve here, which is called the tricuspid valve. It's called tricuspid because there are 3 cusps, 1, 2, and 3. And then we have this valve here. This is called the pulmonary valve because this is the valve that leads to the lungs. On the other side of the heart, this is the equivalent of the tricuspid valve on the left-hand side of the heart. This is called the mitral valve. Why it's not called the bicuspid valve, nobody knows. It's just called the mitral valve. And this is called the aortic valve because this is the valve that leads blood to the aorta and therefore the body. And these valves are really paper thin, almost tissue paper thin, and often translucent when they're behaving normally. So we'll come back to the valves of the heart in a little bit, but I just want to talk to you a little bit about neuroendocrine tumours. Look, as I'm sure you're all aware, they can occur anywhere, but often will occur in the gut region, and they are embryologically based tumours, and they may or may not, but many do, secrete various hormones. There's a whole raft of hormones, including, and particular relevance for us is a hormone called serotonin. And it's the serotonin, it's felt that it's serotonin that predominantly causes carcinoid syndrome, which especially occurs if there's spread of the net to the liver or in the retroperitoneal space. So that's the space sort of at the very back of the gut, or if the net exists in the lungs, which is pretty uncommon, but can occur. And carcinoid syndrome is really the syndrome where people, as a result, particularly of serotonin, may get flushing, wheezing, diarrhea, or combinations thereof. And it's also particularly relevant for this talk, because carcinoid syndrome is where we start thinking about the heart becoming involved in the disease process. It's, you know, one of the things with cardio-oncology in general, and certainly in neuroendocrine tumor, but not just that, in lots of areas where we're dealing with the heart and cancer, there's a lot that's still unknown. So much study is still to be done. Often we can't give specific answers. So, for example, what proportion of people who have carcinoid syndrome will ultimately have a problem with the heart? Nobody really knows, because a lot of the treatments now that are being given, the somatostatin analogs, which help to suppress carcinoid syndrome, are thought to really help protect the heart from the effects of the circulating hormones. But look, in the old days, they used to talk about somewhere between 10 to 30% of people with carcinoid will have their heart affected. But as we go a bit later in this talk, I'll explain to you as well why that figure is really hard to be certain about, because lots of people without carcinoid syndrome and lots of people without NET can have very similar issues with their heart. And so we'll talk about that in a moment. So carcinoid heart disease is the term that is used with when NET tumors that are producing serotonin have a significant effect on the heart. So that's basically what we mean when we say carcinoid heart disease. And, you know, a quick run through history, which is, I think, often, interesting. You know, the first description in the literature of what would ultimately become known as carcinoid syndrome was back in an English medical journal back in 1890. And it described a person who had a tumor of their ileum, so part of their gut. Of course, nobody really knew what was going on back then. The term carcinoid was actually first described or termed by a German pathologist who looks decidedly like a very serious and foreboding chap. And then this figure here is probably the first description in the medical literature of a patient with NET with carcinoid heart disease. Was a 31-year-old railway worker in London who was noted to come with flushing, and it was noted that they had quite a loud murmur of their heart. I'll explain why that's relevant. They didn't really know what was going on in those days, but it's probably the first description in 1930, so less than 100 years ago, where it was first described. And then it took a number of years later for carcinoid heart to be more worked out. In fact, only in relatively recent times. So it's also known as, I don't know how to pronounce it really, Hedinger syndrome, because nobody really uses that term, but in case somebody mentions it to you, Hedinger was a pathologist who basically was one of the first people to really describe the effects on the heart. but most people just use the term carcinoid heart disease. And as I said before, it's likely due to the serotonin effect on the heart, but may be related to other things. People are still unsure. And what's the major effect? Well, it causes what we call valvular fibrosis. So essentially, if you think back to that picture of the heart, the muscle of the heart, the internal cavities, aligned with a very thin layer of cells, which helps separate the blood from everything underneath. Almost think of it like a really tight cling wrap around a structure. And it is thought that the serotonin and other circulating hormones causes basically that really thin film of tissue to proliferate and scar up and contract. And so then what happens as a result of that, it distorts the anatomy of those really super paper thin valves. And you'll recall back to the diagram, the tricuspid valve, so that's that one on the right side of the heart, and then the pulmonary valve, they're the major ones affected. And the major effects are what we call incompetence, or otherwise known as regurgitation. So they're the two major medical terms for it. If you speak to cardiologists or other people, they'll often talk to you about leaky valves. And so when they talk about leaky valves, this is what they're referring to, valves that are what we call incompetent or regurgitant. And basically, the valves don't shut properly because of the scar tissue. And so if an analogy I often use with my patients is if you like to watch Western movies, and if you think of a saloon, and you think of the cowboys going in and out of the saloon and those flappy doors, the valves basically open like the cowboys walking out of the saloon, but they don't close shut in the middle, and they flop around too much, and it allows the blood to go through the middle. You can also get what we call stenosis, and stenosis is where the valves don't open properly, and that causes a different problem. But by far and away, the most common problem is the tricuspid valve, and it becomes leaky. Sometimes it can also become restricted in opening. The pulmonary valve will often have equal parts of leakiness or restriction. But the tricuspid is the valve to focus on. And so what does that do? Well, the heart's pretty good at coping with leaky valves and can cope with them for a very long time, depending on their severity. But what it does is it causes the heart muscle to have to pump more volume of fluid. As you might think, if there's blood that's flowing into the right ventricle, and that's squeezing to push blood to the lungs, but then a whole bunch goes back to through that supposedly previous one-way valve, then that blood comes back in, and it's just got to work a whole lot harder. And hearts, a bit like people, don't like to work harder than they need to. And so what happens with the right ventricle after being subjected to this extra load of volume for too long, it starts getting bigger and not squeezing as well. And also when it gets bigger, it tends to stretch the rings of the valves. And so the valves often become more leaky. And so then you get a bit of this vicious circle where the valves are leaky, the heart muscle stops coping as well, it stretches, the valves become more leaky, the heart muscle gets more stretched and less coping, and then you get quite a difficult situation to deal with. So, I'll just go back. This was just to show, this is the chamber. So if the right ventricle is needing to push a whole lot of blood this way to get to the lungs to get oxygen in, but by the same token, it's pushing a whole lot of blood back that way, and the blood's coming up from the body and the head into here and then getting pushed back into the right ventricle, you can just see there's just a whole lot more blood flowing around and a whole lot more work for the ventricle. In terms of the valves, now these are two pictures that I borrowed from the articles that I've quoted. This valve here is not a tricuspid, is not a carcinoid heart valve. This is, this particular person had an autopsy for a different reason. But you see this is really thin material of the valves, and this is a carcinoid heart. And you can see this just it's not the best pictures, but they're actually quite hard to come by. You know, these are a lot thicker. These leaflets here are a lot thicker than those. Just to highlight the point, this is the sort of problem. And when these valves become thicker and they don't move as well, and they don't close as well, and they don't open as well, is the fundamental problem in carcinoid heart. You'll recall that I said that the leaky valves are not restricted to people that have got NET. In fact, I spend a lot of my day reviewing and monitoring patients who have been found to have leaky valves. All of them. They all leak at some point, or they all get restricted at some point. And a large part of my work is to follow up patients on a very regular basis to look after their valves, see how the leakiness or the restriction is going, and work out what we need to do. And if we have a look here, so the tricuspid incompetence, which is the major valve problem in patients that have carcinoid heart, is also a pretty significant problem in the general population that do not have NET. And depending on who you believe and which paper you read, about 60 to 85% of the general population at some point in their life will develop tricuspid incompetence of some degree or another. And usually and often, particularly in the early stages, will cause no symptoms. So a symptom is something that you describe, such as shortness of breath or feeling tired. And it will often cause no signs. And what that means is by examining a person, you won't necessarily be able to pick up that they have a tricuspid incompetence. You may not hear a murmur. It's actually quite a difficult murmur to hear, even for cardiologists, and that's what we do. And often there are no other signs. It's actually best diagnosed with a test called a cardiac ultrasound. Now, I'm sure some of you have had ultrasound, some of you may not. I've got a little sort of video that tells you about ultrasound in a sec. And it usually, tricuspid incompetence usually will only start causing problems when it's severe. When that tricuspid valve is very leaky, when the right ventricle squeezes and a lot of blood goes back, it can go back and then fill up the pulse in the vein in the neck. Now, all of us have got little pulsations in our neck. If you have seen a cardiologist and you see them looking at your neck, asking you to look forward, and they come and peer at your neck, it's not to look for your jewelry, it's actually your earring, it's to look to see if they can see these little pulsing waves. Doesn't mean that you've got tricuspid incompetence if you've got these waves, because lots of people have them. They're really obvious when like seriously obvious when you have a significant tricuspid incompetence. And then if the right heart starts to fail, the symptoms are actually tough, because they're often symptoms of other things, including NET itself without carcinoid heart disease, such as fatigue, shortness of breath. You can get swelling of your tummy, discomfort in the tummy due to fluid, and also swelling of ankles. And of course, there's lots of other reasons to have swelling of ankles. And I would say, I don't want to be sexist, but 99% of every woman I've ever asked if she has swollen ankles tells me she does. even if I can't see it. It's just a thing I don't understand, and I've learned not to argue. But you know, it is really difficult from signs or symptoms to try and work out whether someone's got NET, which is why for cardiologists, we very much think that the ultrasound is really part of the clinical examination almost. So we use ultrasound a lot. Now, I think my next slide is a little video. And please forgive, it's a Genesis Care video, so there's a little bit of it's often shown for promotional purposes. That's not why I'm showing it today, but I think it's a pretty good video. It got vetted by my wife. She said that was appropriate to show and would be quite good. So I'll just pop it on. I think it's the next slide, and it is. And I'll start it. And it's about a minute and a bit. And if you know, for those of you who perhaps haven't had an ultrasound, this is what you can expect.
Echocardiography is a type of ultrasound which uses sound waves to create images of your heart. It is also referred to as a cardiac echo or simply an echo. Echocardiography is an easy way for your cardiologist to assess your heart muscle, valves, large blood vessels, blood flow, along with information about the blood pressures within the chambers of your heart and lungs. How to prepare for your echocardiogram test. Wear a shirt or blouse, as you'll need to undress to the waist. Females will be offered a gown for privacy. Do not wear talc, body lotion or neck chains. And you do not need to fast for an echocardiogram test. You'll lie on an examination bed on your left side, so the sonographer can get a good view of your heart. You should not feel any major discomfort. Small metal discs called electrodes will be attached to your chest. Leads will be attached to the electrodes so we can monitor your heart rate during the test. To get images of your heart, the sonographer will put a thick gel on your chest, which may feel a bit cold. The sonographer will place a handheld piece of equipment called a transducer directly on the left side of your chest over your heart. The transducer sends and receives sound waves that are not audible. The sonographer may press firmly as they move the transducer across your chest and abdomen, and you may be asked to briefly hold your breath for a short time. For most of the test, you will lie still. The images obtained will be sent directly to the cardiologist for reporting. Once reviewed by the cardiologist, the report will be sent to your referring doctor, usually within a few days. For any urgent abnormal results, the cardiology team will call your referring doctor to discuss. Or your doctor can call our cardiology team at any time with questions.
So that's obviously a schematic sort of view of an ultrasound. There are some inaccuracies now with the pandemic and fears over transmission of virus, both from our staff to patients and patients to staff. There have been a number of changes in terms of lying on your left or right hand side, whether electrodes are put on, and the duration of the test. And things have been reworked to try and minimize risk of transmission either way to make the test safer. We certainly have had no reported cases of transmission during a test. I mean, in Australia, of course, we're fortunate that this terrible plague is seemingly under control. So if you do have an ultrasound, if you had one recently, and it's a bit different to that would be the major reason. You saw on the ultrasound a real image. Oh, hang on a minute. That's not right. So this is the sort of image we see. This side here is the right ventricle. It's on the left-hand side, but that's just the way things are done. This is the right atrium, and this is the tricuspid valve here. And one of the really important tests is what we call color Doppler. It detects the motion of blood and will give it a certain color. And normally you should see color heading that way. And then when the right ventricle squeezes, you shouldn't see color coming back into this chamber. Now, this is a very short clip. I'm sorry, my longer clip seemed to stop working just recently. but you see this greeny color, bluey color that's coming into that bottom chamber. That's the leaky valve. That's the blood flowing back into the right atrium, and is the problem. So, how do you treat carcinoid heart disease? Well, first of all, one of the major underlying things is to treat the NET and the secretion of serotonin. I'm certainly not going to start talking about the ways to treat NET or to treat the serotonin release, because it's not my area of expertise. That's why your medical oncologist or your endocrinologist, if you have an endocrinologist who treats your NET, will manage. And the other point then is the heart might not actually need any treatment. Okay, just as I said before, a lot of the general population have leaky valves, and all we need to do is monitor, because as I said, the heart is really good at coping with leaky and restricted valves up until a certain point. So there are many patients that we follow for years, if not decades, with leaky valves that don't need any treatment. If we do need to treat, if the heart is starting to struggle to cope, there's basically the first step is sometimes restricting the amount of fluid or salt that you have. There are what we call diuretics, and these are medications that help or promote people to pass urine and pass water and get rid of some of that excess fluid that tends to accumulate when hearts start to not cope with the stress. And then there are other drugs. There's a drug called digoxin, which interestingly is one of the oldest drugs we have in cardiology, that comes from the foxglove plant, still used and still useful in certain circumstances. And then some other drugs as well, which can be used. But as you might appreciate, what you're dealing with is a mechanical problem of the valves. And it's really hard to overcome that extra stress on the heart with medications or fluid restrictions when the underlying problem is mechanical. And so often in tricuspid valve disease or pulmonary valve disease, or in fact any valve disease, if it gets bad enough and the heart muscle is starting not to cope, and that's pretty much the key, when the heart muscle is starting not to cope, but at the very beginning, because you don't want to leave it too late, then it usually requires a mechanical solution, which is a surgical procedure to either repair or, in NET in particular, to replace the valve. And that's an open heart operation. And to be honest, not many are done in tricuspid valves, not in NET patients and not actually in the general population either. There's lots of reasons for that. And part of it is perception. So, you know, I'm moderately old. In my training as a cardiologist, I was told that tricuspid valves are not really that important. We can live without them, and you can let them get as leaky as you like, and it will make very little difference. That's not true. It might have been true 35 years ago when people weren't living as long with other health conditions. But now that, you know, I will often have days where I will see so many people in their 80s and 90s, for example, that don't have any malignancy, and some that do have malignancy. You know, as people get older and people are lasting longer for various reasons, the relevance of these valves become more important. That's why cardio-oncology has become more important, because so many more people, because of all the new and progressing treatments for various malignancies, including NET, have caused a big improvement in how long people live, and we want to make sure we maintain quality of life and longevity as best we can. So it was said, first of all, that it wasn't needed to be done 35 years ago. And then it used to be said, oh, it's way too dangerous to replace tricuspid valves. It's a very dangerous operation. And so people didn't do it for that reason. But in fact, with improvements in medicine, there is certainly, it's much less riskier now, provided the timing is done right. Still a pretty significant procedure though. It's not something that you undertake lightly. We'll basically, in particular for NET patients, usually if they need to have an operation to fix the tricuspid valve, you will usually want to fix the pulmonary valve or replace the pulmonary valve at the same time, because you don't want to go in twice. And sometimes NET, once the valves get to a certain leakiness or problem, it can progress sometimes moderately quickly. And so not always, but often when we're talking about operating on a NET patient, we will want to replace both valves. Currently, you might have heard on TV and news, there's for general patients for other problems, there are valves that are now being put in via the groin, so not open heart surgery. And this is mainly for the left-sided valves, what's called the aortic and the mitral valve. But people are now looking at being able to deliver tricuspid repairs and pulmonary replacements rather, and pulmonary replacements just through a groin as a simple, well, not simple, but complicated, but, you know, significantly less invasive procedure. So to be honest though, it is still pretty uncommon to need to send someone for a tricuspid valve or pulmonary valve repair or replacement in any population. Certainly the last patient that I sent was a not NET patient. It was a patient who had just deteriorated their tricuspid valve. And he's the first patient I've needed to send for probably 5 to 6 years for NET. And I see quite a, for tricuspid replacement, and I see quite a few patients with valve lesions. So what should you ask? I mean, that's a quick overview of NET, carcinoid heart. You know, in terms of what you should think about or what you should ask, in my opinion, from your treating physician, you know, is my heart involved? Is a really good start. And ask the question, do you think my heart's involved? Please remember that the examination or the history is usually not enough to pick a problem. An echo is recommended. Now, cardiologists have completely different thresholds to oncologists or other physicians or endocrinologists of when to get an echo. For us, it's almost part of the physical examination, and it's a safe, simple, easy test. There's no radiation. It's like pregnant women have looking at babies. It's really not an issue, and it is invaluable. And so it's interesting. One of the questions, you know, how often should I have an echo? Reading the medical literature, where there are papers and papers and papers discussing whether we can, you know, whether this blood test is better than that blood test to work out if the valve is leaky. Well, it's easy. You don't need a blood test to work out whether the valve is leaky. You just do an echo and you see whether the valve is leaky. Cardiologists are pretty simple people. They're much simpler people than your oncologist or endocrinologist. So we're visual people. And if you have a mechanical problem, then it's best just to have a look, and that'll give you the answer. So there are talk in the various guidelines, like the Cancer Network in the US, or I did actually have a look at ENETS as well, and various other cancer societies, and they give, you know, varying opinions on whether you should get an echo every 3 years or 2 years, depending on what your 5H IAA level is, or what your various other level is. As a cardiologist, in my view, and I've got no literature no scientific support to back this up, except if you've got carcinoid, and if I'm treating you, I basically do a yearly ultrasound. And it's pretty straightforward, and we don't have to worry about trying to guess whether there's a problem there or not. So should you see a cardiologist? Well, again, there's differing opinions on that, and different specialists will want to do different things. It's interesting. Many oncologists feel that cardiologists don't know anything about cardiac disease related to cancer. And to be fair, there are cardiologists who don't know a great deal about cancer-related cardiac disease, and they're specialists in other areas. So there are various, it is a big field, and you want to go choose people, if you're going to see a cardiologist, someone who's interested in or has access to cardio-oncology expertise. As I said, there's a few in Adelaide, and certainly there are around the country, and it's growing. And so my view, I mean, these are just suggested questions for you to think about. Should you see a cardiologist? Well, speak to your oncologist or endocrinologist. I certainly think if you've got carcinoid, it would make sense to have a yearly echo. It makes no sense not to, really, in my view, as a simple cardiologist. And, if you ended up needing to have an operation, which is highly unlikely, to be perfectly honest, but this is a key question, because if people and centres are not familiar with dealing with NET, and they're talking about just replacing one valve and not both, then you need to ask, why are you not thinking of both? And there may be a very good reason for that. And look, that's really, that's just highly unlikely that you'll need to be asking that question. But it is an important one to ask if it ever got to that stage. So I think we are good for questions at this point. So I might just stop sharing my screen so I can see you, and then I'll hand the reins over to either Kate or Jess, whoever wants to take them, and I'm all ears.
Fantastic. Thank you so much, Dr. Cehic. That was, you made an extremely complex subject, I think, very clear. It's probably the best presentation I've seen on this subject, and I've seen quite a few. So, and I learnt heaps by watching that. So thank you. I'm deeply appreciative. I think we've all been quite captivated by the presentation, and I haven't seen any questions come through on the chat. While people think of their questions, I did have a couple of comments. The first thing I was going to say is how lovely when you hear someone talking about their area of expertise, and I love the way you got a bit excited when you saw the picture of the heart, and your face started to light up when you were telling us what an amazing organ it was. And I just think, well, that's a lovely indication when the person giving the presentation is clearly passionate and excited by their subject matter. So not everybody feels that way about bits of human anatomy. So yeah, I noted that. I thought, yeah, this is going to be good. This guy really likes his hearts. One other question I had, which other people might have as well, and then you can get queued up with putting hands up or putting messages in the text, and Jess might have some questions and reflections as well. Just one question I had was, do you know anybody with NETs who has had a transcatheter valve replacement yet? We've got one person she's in the eastern states and was about to have one done when coronavirus came to visit, and so that was all put off, and so she's kind of in limbo land waiting for it to feel safe for everybody to proceed with that. But I was wondering if you've heard any experiences of NET patients, and whether there's any particular considerations for NET patients with that particular procedure.
Yeah, so I've not, I do not know of any NET patients that have had a transcatheter tricuspid procedure. To be honest, I don't know of any general patients that have had a tricuspid procedure. It's still, it is really early technology for the tricuspid valve. In terms of sequence, the aortic valve called aortic stenosis predominantly has been the first valve that's been treated. The pulmonary and aortic valves are the easier ones to treat. They are simpler valves. The tricuspid and the mitral valves are much more complicated mechanically. And in fact, there are trials ongoing with mitral valve transcatheter, and there have been some trials with tricuspid. Now, one of the things, and there's a distinction, is are they, and this is a question because I don't know, but are they having their tricuspid valve replaced percutaneously via the skin, via a catheter procedure, or are they having their symptoms relieved by putting percutaneous valves in their in the vein leading up to the heart? So certainly that's a procedure that is done every now and then in patients to try and relieve some of the symptoms of swelling, of distended abdomen, of fluid buildup where surgery is not possible. But it's a different matter than fixing the valve. And so certainly that is more commonly done, but it's not actually a procedure on the valve itself. And so that would be an important distinction in that area to understand. I have no doubt there will be transcatheter, catheter-based solutions to tricuspid valve, because the structural heart space, so that's the area of specialty that relates to cardiologists sticking tubes in via arteries and replacing valves, has progressed amazingly in the last 5 to 10 years. And I'd have no doubt that in the next X period of years that tricuspid valve replacement will become more capable, or the capability will become more. But at the moment, it's still pretty much investigational and rarely used.
Thank you. That's really a useful comment. So thank you. And I hadn't heard of that procedure that you were talking about. It sounds like actually putting in an extra valve.
That is correct. So they basically put a valve that's intended for the aortic position as a one-way valve into what's called the inferior vena cava, or near the inferior vena cava, to stop the blood flowing back down and causing the congestion in the abdomen.
Well, thank you. I can see, Jessica, you've got your hand up, so it's very good modelling. And I can see also there's a couple of questions come through the text. So I might throw to Jess, and then we can see that'll give me a chance to read what's in the comments box.
No worries. Thanks again, Dr. Cehic. It was an amazing presentation. I really enjoyed it. My question was on the timing of the surgery for NET patients. I'd really like to know, obviously it's a procedure that's not without its risks itself, especially with patients who have active carcinoid syndrome. When would you feel it would be appropriate to take that next step and to consider valve surgery for patients with NET?
That of course is a great question, Jess, and look, it's a tough question to answer in NET patients and in any patient. And so let me, if you like, run through the thinking process that cardiologists do when they're trying to work out what to recommend in these cases. So there's a couple of key principles, particularly with leaky valves. So you generally don't interfere with a leaky valve unless it's either causing symptoms that you can't control with medications, or you're starting to see the heart muscle decompensate or not be able to cope with the extra volume load. The trouble is that you have to time it between not leaving it too late, because if you leave it too late, then if you replace the valve, you're not actually, you won't help, because the damage to the heart muscle is already done. And then the heart will actually find it harder to cope with a non-leaky valve, and you can get into big trouble. In fact, it's one of the the causes of not surviving valve surgery. So you want to leave it so that it starts getting, bad enough to do. And so you might say, well, why not just do it early when you're in great shape and there's no major problems? And that's because there's a risk. And so, at what point do you weigh up a risk that 1 in 20 will perhaps not survive versus potentially being able to survive without a valve replacement, in the worst cases for another year or two? So it's this timing, and it is so personalised that there aren't a set of rules, particularly for tricuspid valves. Depends on the patient, their symptoms, what the heart muscle's doing, how leaky the valve is, what their tolerance to risk is, what other problems and health-related issues that they have apart from NET, which all play a role. So it's a really complex decision, has to be made in conjunction with the surgeon, the oncologist or endocrinologist, but most importantly with the patient and their family. And so, it's a tough, also I don't have a one-line answer for that. And it's really where, and I'm sure that you've all been familiar with the term multidisciplinary teams and multidisciplinary meetings. That's really where you need a room full of the treating physicians to then liaise with the patient and their family and come up with a decision. So, not meaning to sound vague, but I can't just give you an answer. But the simple one is, when it's bad enough that it needs to be sorted, but not bad enough that you've left it too late.
Thank you. I think that's the, we run it over a lot with Gabby as well in our department, and it really is this fine line between when is the right timing, and I guess that is in discussion with cardiologists and their treating team and the patient itself. So.
And obviously, in the end, it's not the cardiologist generally that's doing it. It's obviously the surgeon. If it's not transcatheter, it's the surgeon, and the surgeon needs to be comfortable, obviously. And so, it's a tough call. But as I said, you can often deal with these things and cope with quite leaky valves for a long time.
There's a couple of questions in the text box which are great questions. So there was a question there from someone who said that they do have carcinoid syndrome. Is there anything they can do in daily life to help protect their heart or keep it from getting worse?
So, I mean, the answer is yes, I guess. Just your, general well-being and good diet, weight, exercise as best you can, just the general principles of good health and looking after yourself is key. In terms of protecting yourself specifically from carcinoid heart, I mean, obviously it's the treatment of the underlying NET. So whatever your oncologist or endocrinologist would recommend what you can do in daily life to help that, then you should do that. Unfortunately, again, in a more specific sense, it's a mechanical problem, and so there's actually very little else you can do to protect or make a difference to a mechanical problem. It's not like high blood pressure or cholesterol, where if you exercise more and lose some weight, make sure you get good sleep, eat well, that you can make a significant difference to those things. When you've got a mechanical problem, and this is not just NET patients, this is all patients with valvular diseases, there are some general principles, but there's not a whole lot you can do from a day-to-day basis to make a difference.
Thank you. I'm going to invite Jess to feed the next question in so that you don't hear too much of one voice.
No, that's great. It's great that everybody's getting so involved in the question line. Is it that the lung primary with carcinoid syndrome, is it the same effect? Is it mainly the aortic valve that is affected, or is it the mitral valve in that instance?
Yeah. So, as I said, it's mainly the right heart that gets affected, because that's where the blood drains. The left side of the heart certainly is more susceptible to being affected in lung net, or in patients that have got what's called a patent foramen ovale, which is basically a hole between the two sides of the heart, which happens in a proportion of people just naturally. And it's interesting because the left side of the heart has previously said to be protected from NET because the serotonin gets deactivated by the lungs. There's some recent information coming out to suggest that may not be the mechanism. And so that's what we've been taught and led to believe, but that might not be right. It's again one of those areas that we're not sure. But certainly, you know, if it's draining, if it's in the lungs and it's draining directly into the left atrium, it's more likely to affect the left side of the heart. That is correct. But the left heart doesn't seem to be as susceptible. And the advantage, of course, is the treatments for the left side of the heart are much more mainstream in terms of valve surgery and probably safer too.
Excellent. Well, I didn't know that, so that's something I've learned today as well. We've got another question here that says, apart from the damage it does to the heart tissue, does serotonin overstimulate the heart, and is that a problem?
So the basic answer is no. It basically doesn't really. It's not a stimulation issue. It's a scarring of the valvular structures issue more so than that. There are some other nets though that of course can overstimulate the heart. You know, ones that release adrenaline as their hormone rather than serotonin, and that can overstimulate the heart. And there's a whole lot of issues that can happen there, but not so much with NET, or not with NET.
Daniel, can I just ask with that? I'm not sure if anybody in this room is in this situation with the adrenaline secreting tumours, but we do have quite a lot of people in our network who do have those sorts of tumours. So just for the benefit of those who might have an opportunity to watch this video at home at a later stage, are there any brief comments that you could make around the sort of care that a cardiologist would be, would be offering or looking at for someone with a pheochromocytoma?
Mm. So pheochromocytomas, are adrenaline-secreting tumours, and adrenaline is actively involved, particularly from the heart perspective, in terms of blood pressure. So often blood pressure control can be quite difficult in patients with pheochromocytoma, and that, again, in the old days was all that you really knew about pheochromocytoma and its effect on the heart. In more recent times, in the last 15 years, I guess, a condition called Takotsubo cardiomyopathy has really been discovered. And Takotsubo, I think it's Japanese for octopus head or something. It was first described by the Japanese, and it's a particular appearance on ultrasound of the heart muscle when it gets affected by this condition. It is when people talk about they died of a broken heart or they got scared to death. Well, the history is probably that it was probably Takotsubo cardiomyopathy that started that journey of description. So it's said to occur because of a adrenaline release and probably some sensitization. So the heart's more susceptible to the adrenaline that's released, and can cause a temporary, very significant weakening of the heart muscle. It's really poorly understood. We've certainly seen patients develop Takotsubo when they had their surprise 50th birthday party, and they walked in the door and everyone jumped out from behind the curtains and yelled surprise, and they basically, you know, nearly died as a result. And so that's really rare. One of my colleagues treated a patient like that. I've certainly seen a number of patients with Takotsubo from instances of stress, or one where I still look after her. It's 20 years down the track, where her husband passed away, unfortunately, from a cardiac arrest in front of her, and she went on to develop Takotsubo instantly, pretty much, and she ended up in hospital that day as well, and was quite sick, but has done very well. So they're the two influences really for FIO. I mean, there's a lot of discussion over Takotsubo cardiomyopathy and malignancy, and not just FIO, but in other malignancies as well. It's really an area under intense exploration, and nobody really knows the answers, but that's relevant for FIO.
Thank you so much, and I apologise for dropping the out of left field question on you without any prior notice.
That's all right. Glad I knew the answer.
Do other people have questions? Jess, did you have any questions that you were pondering while you were listening?
No, I think mainly mine was about the timing and surgery, but I think everything else that I was thinking got addressed during the talk. So thank you very much, Dr. Cehic. We really appreciate you taking the time this evening. And if nobody else has anything to add or any other questions, we'll let you get back to your evening.